Okay, before we begin, reminders to all attendees of the 12th Biennial Symposium. You may type in your questions regarding the lecture in the chat box, and the speaker lecture can answer them in the chat box, or you may personally communicate with the speakers by sending them message to our email address. Kindly answer our evaluation form after the last speaker of the session. The link will be seen in the chat box. And last but not the least, for our topic this afternoon, we have already shared the basics of ultrasound, and we have already discussed the point of care regarding the lungs and the heart. And now we're going to go into the extremities. So for our last and final topic for this afternoon, the speaker had his fellowship training in cardiology at the Chinese General Hospital, subspecialty training in peripheral vascular medicine at the Philippine Heart Center, a fellow at the Philippine College of Physicians, Philippine Heart Association, and the Philippine Society of Vascular Medicine. He is currently a consultant staff at University of Santo Tomas Hospital, Chinese General Hospital, and Philippine Heart Center. Ladies and gentlemen, let's all welcome Dr. Frederick Allen Fuentes, MD, for this topic on the duplex ultrasound. And flash before you are the following objectives of this topic.
Good day, colleagues and friends. So I am delighted to share with you this topic, and I thank the organizing committee for inviting me to discuss and share with you this focus on vascular duplex ultrasonography. So the focus or point of care ultrasound duplex can be used to diagnose deep vein thrombosis in our patients. So if we are thinking of diagnosing or suspecting DVT in our patients, we can use this, but it can also be used to diagnose acute limb ischemia. But I will not touch on this topic because it requires a lot of time, more than the 30 minutes that's allotted to me. And because most of the time acute limb ischemia can be diagnosed with a handheld Doppler device. So focus for deep vein thrombosis is used because DVT is a disease that has a significant morbidity in that it causes post-thrombotic syndrome, wherein there is lingering pain, chronic pain, chronic leg pain, discoloration, and of course, because of the mortality that can result from the DVT when it embolizes to the pulmonary circulation, via massive pulmonary embolism and therefore leading to death. And if the patient happens to survive, any residual thrombi in the pulmonary circulation may result to the disease entity known as chronic thromboembolic pulmonary hypertension. And so there are several reasons where a focus for DVT can be requested, and one of which is leg swelling or edema as a workup for DVT, especially if it's unilateral and especially if it's not explained by other factors such as cellulitis or infection. It can be also due to leg pain, or if there's suspicion of DVT from unexplained lab results. For instance, if you have an increasing D-dimer, especially now in our COVID-19 patients, that is somewhat not tracking with the inflammatory markers, and you suspect that there is thrombosis going on somewhere. And because in our supine patients, edema may not be that obvious or marked. Of course, we also use the DVT screening or focus for DVT if we want to use intermittent pneumatic compression device as prophylaxis for our patients against VTE, or venous thromboembolism. So before applying the sleeves or the intermittent pneumatic compression stockings, we want to make sure that there's no underlying DVT that can be embolized by the application of this IPC. And it can be part of the workup for our pulmonary embolism. Say you're suspecting a DVT concomitantly with a PE that you've just detected. So compression ultrasonography in our center, in our heart center, is otherwise known as DVT screening. But CUS, or compression ultrasonography, is the international term to refer to just the compression of the veins to know whether there is DVT or not. And it can be proximal only or a whole leg compression ultrasonography. And it is because the majority of the significant thrombi are found in the proximal veins, namely the common femoral vein, the femoral vein, and the popliteal vein. So this spans the area from the groin to the thigh and to the knee, behind the knee. And the whole leg is the proximal plus the veins in the calf or the legs, namely the posterior tibial and the peroneal veins, as well as the other muscular veins. And of course, you often hear the term venous duplex scan, or VDS. It actually refers to the compression ultrasonography plus reflux testing. So we request venous duplex scan if we are interested in knowing whether our patient has chronic venous insufficiency or reflux disease. So normally we don't do a POCUS for that because that disease is not fatal. It's not immediately fatal, no? And it can be done on a regular basis in a regular lab. So really, it's just the DVT that we are interested in. So meta-analyses have shown, as reported by various and others, that the sensitivity and the specificity for our POCUS ultrasound for DVT is quite high, ranging from 90 to 95 to 98%. Now, the procedure begins with the patient supine, with the head elevated 30 to 45 degrees, and with the leg externally rotated so that it exposes the inguinal crease or the inguinal area or the groin more adequately, and then proceed with application of the gel, and then slide the transducer about 1 to 2 centimeters downwards distally. So you start from the inguinal crease to the thigh, to the behind the knee or the popliteal fossa. And if we are pursuing a whole leg ultrasonography, then include the leg as well. 2 is to scan the following veins: DIV, CFV, FV in the thigh, popliteal vein behind the knee, and in the leg, the posterior tibial and the peroneal veins. Now, of course, we would want to choose the correct transducer for this, and it's the linear array transducer that we use for these vascular structures because these structures are superficial, and the linear array has a higher frequency because the structures are superficial and providing a superior image quality. So normally, we use the highest frequency that we can that can produce an adequate image. And of course, as we go deeper in some of the structures, or if the patient is obese, has a high BMI, then we may have to drop the frequency a little bit so that it has more penetrating power so that the image is clearer. Okay, so for DVT purposes, we use the linear array on your far right transducer with a high frequency. All right. So first, we have to be familiar with the anatomy of the venous system of the lower extremity. So the external iliac vein above the inguinal ligament becomes the common femoral vein below the inguinal crease. And you can see that the common femoral vein is joined by the deep vein of the thigh, or the deep femoral vein. And then it proceeds to become more distally along the thigh, the femoral vein. The femoral vein is also known as the superficial femoral vein, but we drop the superficial term to it so as to reduce any confusion, because it's actually a deep vein and it's not a superficial vein. So we only refer to it as the femoral vein. Now, as it passes through the adductor canal in the distal thigh, it becomes the popliteal vein, and then it trifurcates, into the three veins of the calf, and these are the crural veins, namely the peroneal vein, the posterior tibial vein, and the anterior tibial vein. So the peroneal vein and the tibial vein are along the medial aspect of the leg, while the anterior tibial vein is along the anterior of the tibial bone. So on your right, you can see the B mode image of the distal external iliac artery in red and the distal external iliac vein in yellow. And then when we apply color, we switch on the color flow. It can show the image on your lower right, showing the two vessels side by side. So you can appreciate that the artery is actually more lateral to the vein. So these images are of the right groin, just above the inguinal ligament. Okay, and then when you slide the transducer down, then you are gonna meet the femoral vein. So it's important to be able to distinguish on ultrasonography between the vein and the artery. So in red here on your image on the right, the artery is really more round rather than oval, and it's pulsatile, obviously because of the pulsatility of blood that the cardiac muscle pump function creates, and it's slightly smaller, and it has well-defined walls, and often with plaques or calcification. So often, especially in older patients, you can actually make out the calcifications along the walls of that artery. And when direct application of pressure is done, when you apply pressure, the artery only partially compresses. So you can just barely notice deformation of the artery. But for the vein, it should really fully collapse. You should be able to oppose the two walls, the anterior and posterior walls of the vein, so as to ascertain that there is no thrombosis. So when you're able to compress it, that means there is no thrombus. So this is an image that transposed the anatomy here of the venous system on an actual leg of the patient. So you can appreciate that the left leg is slightly externally rotated to expose adequately the inguinal crease or the groin. And you can see the common femoral vein there is being joined by the great saphenous vein, okay, medially. So when you see that, you know that you are along the common femoral vein. And when you go downwards more distally, you will meet the bifurcation of the deep femoral vein and the femoral vein. And then it spans the whole thigh, the femoral vein, to become the popliteal vein. And then your three calf veins in the leg. Okay, so on the image on your ultrasound, you can see the configuration as follows. No? So we take the left thigh as an example. You have the transducer number 1 oriented like so in a transverse orientation, and it will give you a view of the common femoral vein sitting medially to the common femoral artery. So the veins are in blue, the arteries are in red. You slide it, while at that, you can see that the great saphenous vein is joining or draining into the common femoral vein. When you slide it down about 1 to 2 centimeters, you will see this Mickey Mouse sign. So the Mickey Mouse sign, the two ears of the Mickey Mouse, are formed by the arteries, the superficial femoral artery and the deep femoral artery, which bifurcated from the common femoral artery. So the arteries bifurcate more proximally than the vein. And the head of the Mickey Mouse is formed by the femoral vein. And you can still make out the great saphenous vein there, which is a superficial vein. It's not a deep vein. And it forms the Mickey Mouse sign. So you'll know that you are at the femoral vein. You slide it downward still, and you will see the femoral vein below the artery, along the whole thigh. And the artery is on top. So the structure on top would be actually closer to the transducer. Sometimes, though, the femoral vein is located more medially, and rarely it even is found laterally to the artery. No? So be aware of the slight variation in anatomy and location. And then going to the popliteal fossa behind the knee, you will see that the position changes. The relationship changes in that the vein now is on top of the artery. So be aware of these changing locations because it might lead you to falsely conclude that there is a thrombus when there's none. Because as you know, the artery cannot be compressed. So if you are mistaking the artery as the vein, it might lead you to conclude that there is a thrombus because you cannot compress it. Now, on your right, you can see the longitudinal orientation. So you simply flip or you simply rotate the transducer 90 degrees from the transverse position, shown in number 3. Okay, so you can see the longitudinal orientation at the femoral vein as well as in the popliteal vein. All right. So the technician, the sonographer, or the doctor in this case, because it's a focus exam, is holding the linear array transducer there with the patient relaxed and properly positioned, and copious application of gel is demonstrated like so. All right, the leg is slightly rotated so that it exposes the inguinal canal or the groin adequately. So the physician, starts the procedure in the transverse view or the sax view, putting the transducer just below the inguinal canal or the inguinal ligament. And this is what you'll see on your B mode on your left. You have the vein more medially located, and upon adequate compression of the transducer, you can see there's slight deformation of the artery and there's complete collapse of the vein. That is the normal finding. That means there is no thrombus in that vein segment. And this is what is actually being done in our DVT screening in our center. So when you request DVT screening, then it involves performing this to be able to answer if there's DVT or not. And sliding further downwards, you will meet the common femoral vein as the great saphenous vein joins it. These two will meet because the great saphenous vein drains into the common femoral vein. Okay, so with the patient, with the probe now slid somewhere at the mid to the distal thigh. So the femoral vein dives into the adductor canal. So it may be more difficult to visualize the vein because it is deeper in location at this segment. So you may have to readjust the focus level of your ultrasound. And what it will show you is that the vein is below the superficial femoral artery. And then when you apply pressure, the vein collapses like so on your right. And then the procedure is repeated, this time in the longitudinal position. So the probe is again brought to the inguinal, to the groin, and the longitudinal view is now done. The probe is, rotated 90 degrees, and it will show you the longitudinal section of the veins. So starting off with the distal external iliac vein, and when you apply color, it will show the color flow or the flow direction from the foot to the heart. So it shows you the beautiful color flow completely filling this vein segment. And sometimes we can or you can see the vein valves themselves, which are mobile and flapping. These are not abnormal findings. Sometimes they can be seen, but when you apply color, you can see that there's color flow, so there's no thrombus. And when you compress, it is compressible. Okay, while there, at the longitudinal view, you apply pulse wave Doppler, and you can see this venous waveform pattern. You can ask the patient to do the Valsalva maneuver, inhale and hold it. You can appreciate the cessation of venous flow. The Doppler waveform below the baseline ceases. And when the patient exhales, you have commencement of the venous flow. So this is what is called the respiratory phasic or the phasic venous flow pattern. This is the phasic venous flow pattern as shown here with the pulse wave Doppler sample volume placed at the common femoral vein. So this is helpful to rule out indirectly any obstruction upstream or more cephalad. For example, if you have obstruction along the iliac vein in the pelvis or in the inferior vena cava, then you will have loss of this phasicity or the venous flow pattern. This one is the pulsatile venous flow pattern shown here, which is seen in right-sided heart failure. So you can see you have positive and negative components. You have above and below the baseline. And it's pulsatile. It's not the usual venous flow pattern. So this is a evidence for right-sided heart failure or a severe tricuspid insufficiency. So such a condition can in fact be seen as part of the focus. And so the transducer is slid further down to view the femoral vein in longitudinal section. And then the transducer is placed behind the knee in the popliteal fossa, beginning in the transverse position again, as demonstrated. And it will show you that the vein now is on top of the artery, with the artery inferiorly. Now the vein is actually closer to the transducer. That's why it's on top, because the vein is actually posteriorly located to the artery in the knee. But because you place the transducer at the back of the knee and the vein being closer to it, then it's the one on top. And then finally, if you are pursuing to diagnose any DVT in the calf veins, then you can certainly extend your focus to involve the leg veins or the calf veins. And you position the transducer beginning in the transverse position again to scan for these vessels. So normally, we only scan the posterior tibial vein and the peroneal vein because it's rare to have thrombi in the anterior tibial vein. And even if they do, they are rarely associated with significant pulmonary embolism. So you may want to be interested in pursuing the calf veins because in a certain percentage, some calf vein thrombi can propagate more proximally and therefore cause pulmonary embolism. All right, now this is the anatomy again in the calf. You will see that the posterior tibial vein, PT, and the peroneal vein can be seen or approached medially on the leg. So the transducer is placed like so in the transverse position again, with your other hand providing a counter pressure because the leg may swing. So as you may have noticed, this scan can be done with the patient supine with the leg folded, or if you want to provide more dilatation to the veins because of gravity, you can actually ask the patient to sit and dangle the legs. So you can have more engorged vein segments. So this is how it looked like. The posterior tibial veins and the peroneal veins, as you know, are paired veins. And so they are seen flanking an artery. So in this case, the red color are the arteries. They are flanked by the paired veins. PTV1 and PTV2 refer to the posterior tibial vein, and the peroneal vein is farther to the transducer. You will see the shadow on your right. It's actually the posterior acoustic shadowing created by the tibial bone. So you should be able to compress these vessels. You will notice also there's no venous flow. It doesn't mean that there is thrombus or obstruction. It means that often the flow in the calf veins are not spontaneous, and you may have to squeeze upon the calf or in the ankle area to elicit the flow. And this is another image on the right calf this time. You have the tibial bone on your left on the screen, creating the posterior acoustic shadowing. The PTV again is closer to the transducer, so it's actually located higher than the peroneal vein. And this is the longitudinal view, just as you scan in the longitudinal orientation in the more proximal veins. The same can be done in the calf veins to demonstrate color flow. So the deep vein thrombosis is divided into proximal and distal DVT. And so when we refer to proximal DVT, these are thrombi above the knee, including the popliteal vein. If it's distal DVT, And if it occurs in isolation, then we refer to it as isolated DVT or calf DVT. And these include the posterior tibial and the peroneal veins, but sometimes the muscular veins as well, like the soleal and the gastrocnemial veins. It is believed that the proximal DVT is actually the one that carries a much, much higher risk of embolization, while treatment of the distal DVT can be controversial because some guidelines recommend that you may observe it. But of course, if you notice extension, propagation more proximally, then that can be a sign that it may lead to thromboembolism or pulmonary embolism. Now, what are the DVT criteria for ultrasound criteria? No? So the most important criterion is lack of compressibility. So it's a binary result. You either can compress it or you cannot. So you report it as fully compressible or partially compressible or incompressible. So when you cannot compress the vein segment, that is a direct criterion for DVT. Now, of course, you may be able to visualize the thrombus intraluminally, especially if it is hyperechoic. But if the thrombus is still fresh and it's really black, all you can detect is non-compressibility. And the absence of color flow and Doppler signals are secondary criteria. But the first has to be fulfilled. You should not be able to compress it. And that means you have a DVT. So this is an example of a popliteal vein that contains a thrombus. You can appreciate the heterogeneous hyperechoic density completely or totally occluding the popliteal vein. The popliteal artery is below, and you can know or determine that this is under compression already because the artery is slightly deformed. So the technician or the doctor is actually doing compression already, and the vein just cannot be compressed because of the thrombus. Now, a pitfall is the so-called rouleau phenomenon, wherein you can have this appearance of thrombus because of echo reflections, because of sluggish flow, but there's no thrombus. So the only way to determine that is to compress it. If you have that appearance of a thrombus and you can compress it, then that's a pseudothrombus, and that may be related to rouleau formation. So it just tells you that compressibility is the number one criterion. This is the longitudinal view showing the thrombus. There is an echogenic material within that vein. And if you apply color, you will have absence or partial color flow. And of course, no Doppler signals as well. Now, the question is being asked if it's safe to compress with a thrombus. Really, there is the risk of dislodging or embolizing the thrombus. And that's why if you detect that there is a thrombus more cephalad or proximally already, it is not necessary for you to aggressively compress the more distal segments just to prove if there is DVT or not, because the management will not change anyway. You're going to say that the patient has DVT and you can manage accordingly. The only thing that a more distal scan will tell you is the extent, but the management almost is the same. So you may proceed without aggressively compressing it and just do beam mode imaging without decompression to just visualize the thrombus and apply color. And if there's no color flow, then that can be an indirect sign that there is a thrombus there. This is another pitfall where a lymph node may be mistaken for a thrombosed vein. So it is a lymph node because it is just discrete and it is not connected or continuous with any vascular structure. And when you apply color, you can appreciate color flow within that lymph node. In this picture or image, you can appreciate the two vessels below it, and they are the common femoral vein. The distal external iliac vein and the distal external iliac artery, which are closer to the inguinal segment. And this is an example of a cyst that you can encounter in the popliteal fossa. So a popliteal or a Baker cyst is not a vascular structure. It is a cyst. If you apply color flow, there would be absence of color and Doppler signals. Often it is C-shaped and it is distinct from the vascular structures, which you should be able to demonstrate. So do not mistake this as an aneurysm or a thrombus. Now, of course, you can also scan the arterial circulation and it tracks along the venous system. The only difference is that below the knee, the arteries are not paired, unlike the veins. And of course, they will have a different spectral waveform, as shown here. So sometimes when you are performing the pulse Doppler interrogation, you may inadvertently place it in the artery. So it's important for you to be familiar with the waveform of an artery. So it's shown here. It's multiphasic with positive and negative components above and below the baseline, like so. So letter A is known as the triphasic waveform. Letter B is the biphasic waveform. And you have these other waveforms, and these are the arterial signals. And below that is the venous signal. You can see here the phasic venous spectral Doppler waveform of a vein positioned in the common femoral artery. Now, this is an example of an arterial occlusion. So you will see that the artery is on top of the vein in the femoral, the superficial femoral artery. You can see that the artery or arterial flow is cut off because there is an occlusion or a thrombus in the artery as well. And if you apply color and Doppler signals, they are absent. So I'll flash to you and share with you a clip of a compression ultrasonography in the right lower extremities, starting from the common femoral vein. Here is the distal external iliac vein. Medially, you can see that as the technician compresses, it fully compresses while the artery is not. It's only partially compressible. Now we're in the common femoral vein, and then the technician slides it down to the femoral vein, this time below the artery. Sometimes it's a little medial there. That's the femoral vein. And above it is the femoral artery. So you can see that it is fully compressible. So far, there's no thrombus. Now, this now is the longitudinal view with the transducer rotated 90 degrees, and then application of color and pulse wave. You will appreciate the phasic venous flow in the spectral waveform. So you have full color flow in this segment. Finally, in the popliteal area, you have the popliteal vein now on top. You can see that it's clearly compressible, devoid of any intraluminal filling density. Okay, so I hope you learned from this discussion to be able to confidently perform a POCUS DVT screening or POCUS for DVT in your patients. So thank you for your attention, and I look forward to your questions later. Thank you.
Thank you, Dr. Frederick Allen Fuentes, for the very informative lecture. And in behalf of the Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center, Division of Pulmonary and Critical Care Medicine, and with deep appreciation, we would like to award this certificate of appreciation that reads, the 12th Biennial Symposium, Exploring the New Novel Explicable Wonders in Pulmonology, given the 16th of September 2021 at Quezon City, Philippines, signed by our Chairman, Scientific Committee, Dr. Maria Paz D. Mateo, our overall Chairman, Dr. Denise Ong de la Cruz, our Chair for our Scientific Committee, Johnny John R. Jimenez, the Head of our Division of Pulmonary and Critical Care Medicine, Dr. Eileen B. Guzman Benson, and our current President for our Lung Foundation, Dr. Cesar Antonio. And we would like to invite all the participants to attend the Boehringer Ingelheim Dinner Symposium after the last session.